Welcome to this audiobook on pulmonary infections. We will begin with the demographics of a patient named Katie Taylor. The age is 1 year and the gender is female. Her height is 2 feet 4 inches and her weight is 8.8 kg. She belongs to the white race. She has no known drug or food allergies. Regarding her chief complaint, Katie is a 1-year-old infant brought to her pediatrician's office with complaints of a fever, irritability, and decreased oral intake. Regarding her history of present illness, Katie had been in her usual state of good health until the past 48 hours. Her mother states that she became irritable, is not sleeping on her usual schedule, and is refusing her usual feedings. Katie felt warm to touch with a body temperature of 102.3 degrees Fahrenheit to the mother this morning. Her review of systems is negative except as noted previously. Regarding her past medical history, she was born at term via uncomplicated standard vaginal delivery. She suffered from right acute otitis media (AOM) 4 months ago. This was her first episode. Her immunizations are up to date. Regarding her social history, she lives at home with her parents and older sister, aged 3 years. She attends daycare 5 days a week. Her father smokes outside. They keep no animals in the home or outside. She was breastfed until 9 months of age and is now on formula and transitioning to solid foods. Regarding her family history, her maternal grandmother is hypertensive and her father is asthmatic. Her sister is also asthmatic. On physical examination, generally, she is a well-developed, well-nourished white female, fussy and crying. Regarding her vital signs, she has a blood pressure of 92 systolic 56 diastolic, a heart rate of 124 beats per minute, a respiratory rate of 24 breaths per minute, a body temperature of 101.8 degrees Fahrenheit. She weighs 8.8 kg. Her height is 2 feet 4 inches. Regarding head, eyes, ears, nose, throat, her right tympanic membrane is red and bulging, but immobile. Her chest examination is unremarkable. Regarding the cardiovascular system, her heart has a regular rate and rhythm. Her abdomen is palpable, and non-tender. Regarding her neurological examination, results are within normal limits. Results of the examination of her extremity are within normal limits. Her laboratory and diagnostic test results are within normal limits. A diagnosis of acute otitis media of the right ear is made. According to her medication record, 3 months ago she took Motrin 100 mg, 5 ml, 4 ml orally every 8 hours, Pro Renata for pain and irritability, and amoxicillin 400 mg, 5 ml, 1 teaspoon orally twice daily for 10 days. So my first question to you is, name the most common organisms that cause acute otitis media. Viruses are the most common pathogens in acute otitis media. Of bacterial causes of acute otitis media, Streptococcus pneumoniae currently accounts for approximately 40% of all cases of otitis media. Non-typable Haemophilus influenza accounts for approximately 25% to 30%, and Moraxella catarrhalis accounts for about 10% to 15%. Other organisms found in otitis media, approximately 5%, include Group A, Streptococcus, Staphylococcus aureus, and anaerobes. Combined viral and bacterial infections are commonly seen in acute otitis media. My second question to you reads, a resident asks you about the use of TMP/SMX in acute otitis media. How would you respond? TMP/SMX has a high degree of cross-resistance with penicillin and beta-lactam antibiotics in general. Therefore, if the patient has an infection caused by non-penicillin susceptible Streptococcus pneumoniae, TMP/SMX is most likely an ineffective alternative. It was useful in the past and was often a second-line agent or first-line agent in penicillin-allergic patients. Its use is dramatically lower in pediatrics as safer and more efficacious agents have become available. Not only is cross-resistance a problem, but also the incidence of resistance to TMP-SMX itself is very high and increasing. Most recent studies do not recommend TMP-SMX for treating acute otitis media. Skin reactions have always been a serious complication of sulfur-containing medications. The incidence in children is low, but with many antibiotics that are more efficacious and safer, TMP-SMX should be avoided for acute otitis media. Haemophilus influenza, non-typable, is the second most common organism causing acute otitis media. At least 10% of the isolates are resistant to TMP-SMX, giving further support to not using TMP-SMX. My third question to you reads, describe the mechanism of how Streptococcus pneumoniae develops antimicrobial resistance to beta-lactam antimicrobials. The resistance of Streptococcus pneumoniae to beta-lactam antimicrobials develops due to alterations in the penicillin-binding protein. By increasing the dose of amoxicillin, for example, this type of resistance can be overcome. Thus, 90 mg per kilogram per day of amoxicillin is the appropriate therapeutic dose for otitis media today. The resistance of Streptococcus pneumoniae to macrolides is due to alterations of the ribosomal binding site and by efflux pumps. And my fourth question to you is, name at least 4 risk factors for a higher incidence of or increase the risk of developing acute otitis media. Infants and children exposed to second-hand smoke have a several-fold higher chance of developing acute otitis media and of developing recurrent infections. Day care attendance and anatomic changes such as cleft palate increase the risk of developing acute otitis media. Eustachian tube dysfunction is the most important factor leading to acute otitis media. Numerous etiologies exist for eustachian tube dysfunction, however, when it does not function properly, otitis media and/or sinusitis often develop. Eustachian tube dysfunction prevents removal of inflammatory and infectious material from the middle ear and infection may ensue. Patient age at first occasion of acute otitis media is important. If the infant develops acute otitis media before 6 months of age, the chances of recurring episodes are 50% more likely than in those infants or children whose first episode occurs after 6 months of age. Infants with allergies, atopy, or immunoglobulin G (IgG) deficiencies have a greater risk of developing acute otitis media. Breastfeeding has been shown to provide protection from developing acute otitis media. Infants who are breastfed until at least 4 months of age have significantly fewer episodes of acute otitis media than children who are bottle-fed. Eliminating pacifier use during the second 6 months of life and avoiding bottle propping can decrease the risk of acute otitis media. Vaccinating the infant with the recommended immunizations is beneficial as well. And my fifth question to you is, KT returns to her pediatrician 3 days after the initial visit. She is still having fever and is irritable. Her mother was adherent with the antibiotic treatment. The physician feels she failed amoxicillin therapy due to a resistant organism and asks you to develop a therapeutic plan for KT. What do you suggest? High-dose amoxicillin therapy, that is 90 mg per kilogram per day, was appropriate for the initial treatment for acute otitis media because of the increased prevalence of non-penicillin-susceptible Streptococcus pneumoniae. This is recommended by the American Academy of Pediatrics for non-penicillin allergic patients. If the patient has a non-type 1 penicillin allergy, a cephalosporin can be prescribed for acute otitis media, such as cefdinir, cefpodoxime, or cefuroxime. Antibiotics should be changed if the patient is still symptomatic after 48 to 72 hours of antibiotics, and the diagnosis should be re-examined. If a patient fails amoxicillin therapy, amoxicillin clavulanate is recommended next at a dose of 90 mg per kilogram per day of amoxicillin with 6.4 mg per kilogram per day of clavulanate in 2 divided doses. A 3-day therapy of IM or IV ceftriaxone is an alternative, especially in those not taking oral medications well. If the patient has been initially prescribed amoxicillin, clavulanate or an oral third-generation cephalosporin IM ceftriaxone for 3 days would be appropriate. TMP-SMX is not recommended for acute otitis media due to a high rate of resistance. Because KT has no drug allergies and is tolerating oral medications, amoxicillin clavulanate should be recommended at a dose of 400 mg orally twice daily for 10 days using the 600 mg, 5 ml suspension. My sixth question to you reads, what immunizations should KT receive at her 1 year of age pediatrician visit? At 1 year of age, KT should be administered the Haemophilus influenza type B vaccine abbreviated as HIB, pneumococcal conjugate vaccine abbreviated as PCV13, inactivated influenza vaccine abbreviated as IIV, measles, mumps, rubella vaccine abbreviated as MMR, varicella, chickenpox vaccine abbreviated as VAR, and the hepatitis A vaccine abbreviated as Hep A. If she did not already complete her hepatitis B series or receive her 3rd dose of inactivated poliovirus, she would need those as well. The demographics of a patient named Laurie Robertson are as follows. The age is 17 years. The gender is female. Her height is 5 feet 4 inches. Her weight is 54 kg. She belongs to the white race. She is allergic to grass and tree pollen. Regarding her chief complaint, LR is a 17-year-old female who presents to her primary care provider with redness and tenderness of her left ear. Regarding her history of present illness, LR states that she has noticed that her left ear has been hurting for approximately 1 week. Over the past few days, her ear has become increasingly tender and somewhat red raw, as she describes it, to the point where she cannot lie on her left side or put in her earrings. She states that her ear feels full, but denies any loss of hearing. Regarding a review of systems, her ear is as described above. She denies any headache, blurred vision, photophobia, fever, facial or neck stiffness or tenderness, or jaw or tooth pain. Regarding her past medical history, she had febrile seizures as an infant. She is asthmatic and has mild facial acne. Menarche was at age 13. Regarding her social history, she lives with her parents and a cat in southern Texas. She swims in high school and spends extended periods of time in the pool. She is sexually active with a single, male partner. Regarding tobacco use, she has tried tobacco but denies regular use. Regarding alcohol use, she takes none. Regarding illicit drug use, she has tried marijuana but denies regular use. Regarding her family history, her parents are alive and well. Her mother is asthmatic while her father is hypertensive. On physical examination, generally she is a healthy-looking female in mild distress due to atalgia. Her vital signs include a blood pressure of 100 systolic 70 diastolic, a heart rate of 82 beats per minute, a respiratory rate of 20 breaths per minute, an oral body temperature of 37.0 degrees Celsius. She weighs 54 kg. Regarding head, eyes, ears, nose, throat, she is normocephalic and atraumatic. Regarding pupils equally round and reactive to light and accommodation, abbreviated as PERRLA, examination of the left external ear reveals a tender, erythematous, macerated ear canal, with no obvious pus. Tympanic membrane is intact. There is no apparent involvement of surrounding tissues. Her right ear is normal. Regarding the neck, she has no stiffness. She has a mild cervical lymphadenopathy. Her lungs are clear to auscultation. Regarding her neurological examination, cranial nerves 2 to 12 are intact. Laboratory and diagnostic test results are as follows. Gram stain and microscopic examination of a swab of the external ear canal revealed gram-positive cocci in clusters. No hyphae or white blood cells were seen. A diagnosis of acute otitis externa is made. According to her education record, her home medications include Orthonovum 1/28, 1 tablet orally daily. Claritin 10 mg orally daily. Ventolin HFA 2 puffs every 4 hours pro Renata with cough or shortness of breath. Benzoyl peroxide 10% gel apply to face pro Renata. Naproxen 220 mg orally every 12 hours pro Renata for menstrual cramps. So my first question to you is, list risk factors and the diagnostic criteria for acute otitis externa. Excessive cleaning, such as with cotton swabs, or irrigation can injure the ear canal, making it more susceptible to maceration from water trapped by compacted cerumen, inflammation, and infection. Debris from dermatologic conditions and wearing hearing aids may prompt infections. A short ear canal would make it more difficult for water to be trapped, therefore decreasing the risk of acute otitis externa. Acute otitis externa is more commonly seen in warmer climates, increased humidity, or in patients with increased water exposure, swimming, hot tubs, etc. The diagnosis of acute otitis externa is made when the following conditions are met: 1. Quick onset within 48 hours in the past 3 weeks, and 2. Symptoms of ear canal inflammation, atalgia, itching, or fullness with or without hearing loss or jaw pain, and 3. Signs of ear canal inflammation, tenderness of tragus, pinna, or both, or diffuse ear canal edema, erythema, or both with or without otorrhea, regional lymphadenitis, tympanic membrane erythema, or cellulitis of the pinna and adjacent skin. And my second question to you is, describe the most common organisms that cause acute otitis externa and develop a general treatment plan for LR. The majority, that is 98%, of acute otitis externa in the United States is due to bacteria. The most common pathogens include Pseudomonas aeruginosa, Staphylococcus epidermidis, and Staphylococcus aureus, commonly co-infecting. Infections are usually polymicrobial, with additional pathogens being primarily gram-negative organisms. Fungal involvement is rare but could be seen in chronic otitis externa, after treatments of topical antibiotics, or in patients with hearing aids. Topical antibiotics are the mainstay of treatment for acute otitis externa when no signs of systemic infection are identified, e.g., swelling and pain of the tissues around the mastoid. System antibiotics are rarely indicated. An antiseptic, e.g., acetic acid, antibiotic, corticosteroid, or a combination product may all be considered for initial treatment. Clinical trials have found no significant differences in clinical outcomes of acute otitis externa for various topical combination products, antiseptic versus antimicrobial, quinolone versus non-quinolone antibiotic, or steroid antimicrobial versus antimicrobial alone. Cost, adherence, and adverse effects should be considered when selecting a product for a patient. Patients should be assessed for factors that would modify therapy, such as non-intact tympanic membrane, tympanostomy tube or tubes, diabetes, immunocompromised state, and prior radiotherapy. And my third question to you reads, what if LR's tympanic membrane was ruptured? Which of the following is an appropriate otic product that may be used when the tympanic membrane is perforated? Is it A. Ofloxacin otic solution, or B. Antipyrine and benzocaine otic solution, or C. Ciprofloxacin and hydrocortisone otic solution, or D. Neomycin hydrocortisone and polymyxin B otic solution, or is it E. Acetic acid otic solution? Answer A is correct. If the tympanic membrane is ruptured or the patient has tympanostomy tubes, non-ototoxic formulations must be used. Topical drops that contain alcohol or ototoxic drugs, e.g., aminoglycosides, should be avoided. Ofloxacin otic solution is the only otic solution that is approved for use with a perforated tympanic membrane, as quinolone antibiotics are generally safe to use in the middle ear. Antipyrine and benzocaine, in answer B, should be avoided if the tympanic membrane is ruptured. Ciprofloxacin and hydrocortisone, in answer C, is contraindicated because it is nonsterile. Neomycin hydrocortisone and polymyxin B, in answer D, is contraindicated because it can cause ototoxicity, burning, and stinging. It is specifically contraindicated by the manufacturer for use with a non-intact membrane. Acetic acid solution, in answer E, can cause burning and stinging when used with a perforated tympanic membrane. And my fourth question to you reads, describe techniques that a patient should be instructed to do to enhance the contact of an otic solution with the affected area. First, it is important to appropriately counsel the patient and/or caregiver on how to administer topical drops into the ear. Placing a cotton wick in the ear following installation and manipulating the tragus to effect adequate distribution in the canal are methods that facilitate prolonged contact of the solution with the affected areas of the ear canal and are particularly useful in small children who cannot or will not stay still. An oral toilet can be performed to facilitate the removal of debris from the canal. Warming the solution, usually by holding in hands for 1 to 2 minutes, does not increase the contact of the solution with the affected area but may help minimize dizziness that can occur from installation of cold drops. And my fifth question reads, the antimicrobial properties of acetic acid, which is a component of some otic preparations, are attributable to its A. drying properties, or B. hypertonicity, or C. viscosity, or D. acidity, or is it E. detergent properties? Answer D is correct. Being a weak acid, acetic acid lowers the pH of the ear canal and creates a local medium that is unfavorable for the growth of organisms. And my sixth question to you reads, what are common adverse effects of antibiotics found in topical otic preparations? Topical antibiotics can sensitize the skin, resulting in a dermatitis, which may exacerbate the symptoms of otitis externa and/or interfere with healing. Pruritus is another common adverse effect. Less common adverse effects include discomfort, dizziness, atalgia, vertigo, superinfection, and decreased hearing. The demographics of a patient named Rebecca Thompson are as follows. The patient is aged 68 years and belongs to the female gender. Her height is 5 feet 6 inches. She weighs 135 pounds and belongs to the white race. She has no known drug or food allergies. Regarding her chief complaint, RT is a 68-year-old white female who presented to the accident and emergency department this morning at 01 hours with a 2-day history of productive cough with fever. She also complained of shortness of breath. She decided to seek medical treatment because the chest pain and other symptoms were preventing restful sleep. Regarding her history of present illness, approximately 4 weeks ago, RT developed a urinary tract infection that was successfully treated with a 3-day course of ciprofloxacin. Following a week of being healthy, she then developed a flu-like illness of cough, malaise, and muscle aches that lasted about 10 days. While working in the yard 2 days ago, she had a sudden onset of chills, followed by fever, pleuritic chest pain, and productive cough with mucopurulent sputum. She took 400 mg of ibuprofen and an OTC cough suppressant but still had to quit working and go inside. She has remained at home resting but has not been able to sleep well since the symptoms began. She continued to take ibuprofen 2 to 3 times daily with little relief. Regarding a review of systems, her primary symptoms include new onset of productive cough, dyspnea, and fatigue. Regarding her past medical history, RT suffers from hypertension for the past 7 years and was recently diagnosed with diet-controlled type 2 diabetes mellitus. She has never been hospitalized and has no prior history of pneumonia. Regarding her social history, regarding tobacco use, he smokes 1 pack per day, and 35 packs per year. Regarding alcohol use, he takes 1 to 1.5 glasses of wine per day. Regarding caffeine use, he takes 1 to 2 cups of coffee per day. Regarding his family history, his father died at age 50 of pancreatic cancer. His mother died at age 92 of a cerebrovascular accident. His maternal grandfather was diagnosed with diabetes in his 50s. He has 1 brother living with hypertension and 1 brother alive with no pertinent medical history. He had 1 sister who is deceased due to motor vehicle accident. Regarding his vaccination history, he received the last influenza vaccine 2 years ago. He received AT.DAP booster 5 years ago. His childhood series is up to date. On physical examination, she is generally a well-developed female adult complaining of fatigue, malaise, and chest pain with difficulty breathing. Her vital signs on accident and emergency department admission include a blood pressure of 152 systolic 88 diastolic, a heart rate of 102 beats per minute, a respiratory rate of 26 breaths per minute, and a body temperature of 39 degrees Celsius. She weighs 61 kg. Regarding head, eyes, ears, nose, throat, abbreviated as HEENT, pupils equally round and reactive to light and accommodation, abbreviated as PERRLA, her throat red but without lesions. On chest examination, RALS heard in left lung. On neurological examination, she is alert and oriented on 2 occasions. Her laboratory and diagnostic test results are as follows. Sodium levels of 145 milliequivalents per liter. Potassium levels of 4.1 milliequivalents per liter. Chloride levels of 110 milliequivalents per liter. Bicarbonate content of 25 milliequivalents per liter. Blood urea nitrogen of 36 mg per deciliter. Serum creatinine of 2.0 mg per deciliter. Blood glucose levels of 160 mg per deciliter. Her hemoglobin is 14.5 grams per deciliter. She has a hematocrit of 44%, platelet counts of 220,000 cells per millimeter cubed, white blood cell 15,000 cells per millimeter cubed, with 82% polymorphonuclear neutrophils, 9% bands, 9% lymphocytes. Her chest X-ray shows a left lower lobe infiltrate. Her sputum gram stain demonstrated less than 10 squamous epithelial cells and greater than 25 polymorphonuclear neutrophils per low power field (LPF), with a predominance of gram-positive cocci in pairs and chains. Culture is pending. Her oxygen saturation on room air is 88%. A diagnosis of community-acquired pneumonia is made. Regarding her medication record, her home medications include hydrochlorothiazide 25 mg daily, ramipril 5 mg daily, OTC ibuprofen 2 tablets pro Renata for aches, pains, and fevers, multivitamins with minerals every morning. So my first question to you is, what are signs and symptoms of community-acquired pneumonia, and what is the most commonly identified pathogen? Fever, increased white blood cell count with bands, productive cough, and pleuritic chest pain are all findings of pneumonia. The majority of patients presents with fever and cough, but not all patients will have a cough associated with sputum production. Other findings of pneumonia in RT include tachycardia, tachypnea, and rales in the left lung. Streptococcus pneumoniae is the most commonly identified pathogen in community-acquired pneumonia. It is identified in 20% to 60% of all episodes. RT's use of ciprofloxacin 4 weeks ago does not change her diagnosis of community-acquired pneumonia. However, she would not meet criteria for outpatient treatment due to antimicrobial use within the last 3 months per the IDSA guidelines. And my second question to you reads, all of the following are indicative of an acceptable sputum specimen except A. Greater than or equal to 10 squamous epithelial cells per low-power field. Or B. Greater than 25 polymorphonuclear neutrophils per low-power field. Or C. Less than 10 squamous epithelial cells per low-power field. Or D. Ideally should be collected prior to initiating antibiotic therapy. Or E. Sputum collection is not required to be performed in all patients based on the 2007 IDSA consensus guidelines on the management of community-acquired pneumonia in adults. Answer A is correct. Culturing a poorly collected sputum specimen is a waste of time and money as it will be heavily contaminated with oropharyngeal flora, and the infecting organism will not likely be seen. Therefore, it is important to collect a quality sputum specimen. The IDSA guidelines state that pre-treatment gram stain or culture of expectorated sputum should be performed only if a good quality specimen can be obtained. Specimen collection should be done prior to beginning antibiotics, as in answer D, as the presence of the antibiotic in the specimen may inhibit growth of the organism in culture. However, antibiotics should not be withheld in an emergency situation waiting for a sputum specimen to be collected. Different labs may have varying sputum specimen criteria, but a low number of squamous epithelial cells and a notable presence of polymorphonuclear neutrophils are commonly employed. A quality specimen is often defined as one that contains less than 10 squamous epithelial cells and greater than 25 polymorphonuclear neutrophils per low-power field, as in answer S, A, B, C. The IDSA guidelines also state that sputum samples do not need to be obtained from all patients, as in answer E. Table 5 in the 2007 IDSA Consensus Guidelines on the Management of Community-Acquired Pneumonia in Adults lists indications in which sputum samples should be obtained. Critically ill patients should have diagnostic testing performed. However, diagnostic testing should not be considered wrong for any patient as these tests have an impact on the care of individual patients. Patients likely to have pathogens, which are not covered by recommended empiric antibiotic regimens, should have the specific pathogens identified to better tailor their antibiotic management. For more information, see Clinical Infectious Diseases 2007, 44, Supplement 2, S 2772. These guidelines are also found on the IDSA website, www.idsociety.org. And my third question to you is, RT was admitted to the general medical floor of the hospital with a diagnosis of community-acquired pneumonia. Develop an appropriate treatment regimen for RT. What routine monitoring should be conducted? Common pathogens for community-acquired pneumonia include Streptococcus pneumoniae, Mycoplasma pneumoniae, Haemophilus influenza, Chlamydophila pneumoniae, Legionella species and respiratory viruses such as influenza A and B, adenovirus, respiratory syncytial virus, and parainfluenza. Penicillins, cephalosporins, or respiratory fluoroquinolones are agents with activity against pulmonary gram-positive organisms. Agents with activity against atypical pathogens include macrolides, such as azithromycin, erythromycin, and clarithromycin, doxycycline, and fluoroquinolones. A respiratory fluoroquinolone or a beta-lactam plus a macrolide is appropriate treatment for a non-intensive care unit patient like RT. Ceftriaxone plus azithromycin is an appropriate regimen for RT. It will provide coverage for the most common pathogens associated with community-acquired pneumonia. Doxycycline alone is not recommended for hospitalized patients. Levofloxacin plus azithromycin is not appropriate as the regimen is associated with therapeutic duplication. Levofloxacin or moxifloxacin alone are appropriate therapy in a hospitalized patient. However, RT recently received ciprofloxacin for treatment of a urinary tract infection, and therefore an antibiotic from a different class should be selected to treat RT's pneumonia per the guidelines. Ceftriaxone alone is not appropriate therapy as it will not cover atypical pathogens, such as Mycoplasma, Legionella, and Chlamydophila. Therapy guidelines for the management of community-acquired pneumonia are available on the IDSA website www.idsociety.org. Patients should be monitored routinely, e.g., on a daily basis, for resolution or improvement in clinical findings, as well as potential adverse effects secondary to antibiotic therapy. Chest X-rays lag behind in improvement by at least 3 weeks. Chest X-rays should not be routinely used to monitor response to therapy while the patient is receiving antibiotics. However, if the patient fails to demonstrate a clinical response, a follow-up X-ray while on therapy is appropriate. Abnormal findings on chest X-ray clear more slowly than the clinical findings. And my fourth question to you reads, the microbiology report for RT's sputum culture indicates the pathogen is Streptococcus pneumoniae with high-level resistance to penicillin. Which antibiotic would be suitable to treat RT? Would it be A. azithromycin, or B. trimethoprim, sulfamethoxazole, or C. linezolid, or D. doxycycline? Or would it be E. cefazolin? Answer C is correct. High-level resistance is indicated by a penicillin MIC of greater than 2.0 micrograms per milliliter. This demonstrates that the pathogen is penicillin-resistant Streptococcus pneumoniae. These isolates are often referred to as penicillin non-susceptible Streptococcus pneumoniae. These organisms should also be considered resistant to first- and second-generation cephalosporins, as in answer E, macrolides, as in answer A, doxycycline as in answer D, and trimethoprim, sulfamethoxazole, as in answer B. Quinolones, clindamycin, vancomycin, telithromycin, linezolid, as in answer C, and often third-generation cephalosporins are active against penicillin non-susceptible Streptococcus pneumoniae. However, data suggest that in pneumonia, penicillin MICs greater than 4 adversely affect treatment outcome. Therefore, high-dose amoxicillin or ceftriaxone is appropriate, particularly against isolates whose susceptibility is deemed as penicillin intermediate based on MIC, that is MIC of 0.1 to 1 microgram per milliliter. And my fifth question to you reads, list risk factors for penicillin-resistant Streptococcus pneumoniae. Risk factors for penicillin-resistant and drug-resistant Streptococcus pneumoniae include age greater than 65 years, antibiotic therapy within the past 3 months, multiple medical comorbidities, alcoholism, immunosuppression, and exposure to a child in a day care center. Patients with risk factors for drug-resistant Streptococcus pneumoniae should receive antibiotics that have activity against this pathogen. My sixth question to you reads, which of the following would not be recommended as a preventative strategy for community-acquired pneumonia in RT? Is it A. smoking cessation, or B. one dose of pneumovax that is the PPSV23? or C. Intramuscular fluzone high dose, given annually, or D. Intranasal flu mist, given annually? Or is it E. Proper respiratory hygiene, including hand washing and potentially masks or tissues? Answer D is correct. Smoking is a risk factor for pneumonia, as in answer A. Smoking alters the function of the body's mucociliary transport system. The pneumococcal vaccine is protective against invasive Streptococcus pneumoniae infection. A single dose of pneumovax, that is PPSV23, is recommended for persons greater than 65 years who have not had it in the previous 5 years, as in answer B. The Prevnar 13 vaccine should also be administered to patients 65 years and older who have not received this vaccination. Prevnar 13 should be administered 6 to 12 months prior to PPSV23. The influenza vaccine should be given to those at increased risk of complications, including those 65 years and older. Fluzone high dose is an inactivated influenza vaccine recommended in those greater than or equal to 65 years, as in answer C. It contains more antigen, which has shown to produce greater antibody levels in the elderly. Whether or not this confers greater immunity has yet to be shown. Flu mist quadrivalent is an intranasal, live-attenuated influenza vaccine that is recommended only in healthy patients 2 to 49 years old. Therefore, RT is not eligible for this specific influenza vaccine, as in answer D. Proper respiratory hygiene is important in all ages. The CDC website, www.cdc.gov/vaccines, has additional vaccine information and recommendations. See answer E. The demographics of a patient named Aaron Stevens are as follows. The age is 76 years. He belongs to the male gender. His height is 5 feet 11 inches and he weighs 177 pounds. He belongs to the white race. He has no known drug or food allergies. Regarding his chief complaint, AS is a 76-year-old male who was admitted 13 days ago for coronary artery bypass surgery. Post-CABG, the patient had a slow recovery and remained in ICU because he was unable to be extubated. 2 days ago, he developed a fever and severe abdominal pain. He was subsequently taken to the operating room where a perforated duodenal ulcer was repaired. He has been stable postoperatively in the ICU. Last night, he became agitated, spiked a temperature, and had increasing oxygenation demands. Regarding his history of present illness, last evening, AS became agitated, spiked a temperature to 102.8 degrees Fahrenheit, and had increasing oxygen requirements. FiO2 increased from 40% to 80%. 2 sets of blood cultures were drawn, and a sputum sample was sent for gram stain and culture. A stat chest X-ray revealed an infiltrate at the left lower lobe. A review of systems is negative except as previously noted. Regarding his past medical history, he had a myocardial infarction 1 month ago, CABG ×5 13 days ago, atrial fibrillation, hypertension, hyperlipidemia, diabetes mellitus type 2 for 27 years, benign prostatic hypertrophy, and COPD. Regarding his social history, he quit tobacco use 35 years ago. He takes alcohol occasionally. Regarding his marital status, he is married. Regarding his family history, his mother died of complications of diabetes at age 74. His father died of heart disease at age 67. On physical examination, he is generally an elderly male, sedated, and intubated. His vital signs include a blood pressure of 151 systolic 87 diastolic, a heart rate of 93 beats per minute, a respiratory rate of 28 breaths per minute. His body temperature is 102.6 degrees Fahrenheit. He weighs 80.4 kg. Regarding head, eyes, ears, nose, throat, pupils equally round and reactive to light and accommodation. He is intubated. On chest examination, diminished breath sounds are heard. Rales are heard in the lower left lung. The incision is pink, with no drainage, and it's healing. On abdominal examination, the incision is pink, with no drainage. There is some tenderness around incision. His laboratory and diagnostic test results are as follows. Sodium levels of 136 milliequivalents per liter. Potassium levels of 4.2 milliequivalents per liter. Chloride levels of 116 milliequivalents per liter. His bicarbonate content is 18 milliequivalents per liter. Blood urea nitrogen is 24 mg per deciliter. Serum creatinine is 1.2 mg per deciliter. His blood glucose levels are 228 mg per deciliter. His hemoglobin is 10.2 grams per deciliter. He has a hematocrit of 32.6%. His platelet count is 376,000 cells per millimeter cubed. His white blood cell count is 23,500 cells per millimeter cubed with 68% segs, and 20% bands. Regarding his chest X-ray, there is a left lower lobe infiltrate. Regarding microbiology, blood cultures are negative at 12 hours. Sputum gram stain results are 4+ white blood cells, 3+ gram-negative bacilli. A diagnosis of ventilator-associated pneumonia is made. Regarding his medication record, he received the following. On March 16, regular insulin sliding scale. On March 16, famotidine 20 mg via intravenous piggyback every 12 hours added to total parenteral nutrition on 25 March. On March 16, enoxaparin 40 mg sub-Q daily. Held for 2 days after abdominal surgery. On 23 March, ampicillin, sulbactam, marketed as Unisin, 3 grams via intravenous piggyback stat then, 1.5 grams every 6 hours. On 24 March, midazolam 1 to 2 mg IV every 3 hours pro renata for agitation. On 25 March, morphine sulfate 2 to 4 mg IV every 2 hours pro renata for pain. On 25 March, total parenteral nutrition. On 25 March, enalaprolat 1.25 mg IV every 6 hours pro renata. On 1 April, warfarin 5 mg orally every night at bedtime. So my first question to you is, which one of the following empiric treatment regimens is most appropriate for AS? Is it A. ceftazidime plus gentamicin plus vancomycin? Or B. vancomycin? Or C. ceftriaxone? Or D. piperacillin, tazobactam plus gentamicin? Or is it E. levofloxacin plus metronidazole? Answer D is correct. Late-onset nosocomial pneumonias, that is pneumonias occurring after 5 or more days of hospitalization, are more likely to be caused by gram-negative bacteria, Pseudomonas, see answer A, Enterobacter, or Klebsiella, and Staphylococcus aureus. Staphylococcus aureus is not likely as AS's gram stain demonstrates gram-negative bacilli. AS has been intubated and hospitalized for 13 days, therefore, piperacillin, tazobactam plus gentamicin is the most appropriate choice for AS, see answer D. He has nosocomial pneumonia, therefore, nosocomial gram-negative pathogens e.g., Pseudomonas, Enterobacter, and Klebsiella must be covered. He is currently on ampicillin, sulbactam for his perforated ulcer. Ampicillin, sulbactam does not provide adequate coverage against nosocomial gram-negative pathogens. However, AS does need anaerobic coverage for his perforated ulcer. Piperacillin, tazobactam will provide this coverage as well. The addition of an aminoglycoside, gentamicin, to piperacillin, tazobactam is usually recommended for the treatment of Pseudomonas. See answer D. The combination of an anti-pseudomonal beta-lactam plus an aminoglycoside provides synergy against Pseudomonas. Vancomycin, see answer B, is not appropriate in AS because his Gram stain showed Gram-negative bacilli. Vancomycin covers only Gram-positive organisms. Ceftriaxone does not provide coverage against Pseudomonas or anaerobic bacteria. Levofloxacin plus metronidazole, see answer E, is not appropriate therapy for empiric Gram-negative coverage for nosocomial pneumonia. AS has late-onset nosocomial pneumonia, and the guidelines recommend that empiric therapy for Gram-negative coverage include 2 antibiotics with activity against Gram-negative pathogens must empirically cover for Pseudomonas. Quinolones alone are not appropriate empiric therapy for nosocomial pneumonia, especially in a patient in the ICU. My second question to you is, which one of the following statements is not a risk factor for the development of antibiotic resistance? Is it A. Prior antimicrobial agent use, or B. Antimicrobial stewardship, or C. Prolonged hospitalization, or D. ICU stay, or is it E. Underdosage of antimicrobial agents? Answer B is correct. Prior antimicrobial agent use may lead to increasing colonization and potential infection with resistant organisms. A. Prior antimicrobial agent use may have exerted selective pressure, which may have induced resistance as well. Prolonged hospitalization in answer C and ICU stays in answer D lead to increasing colonization and infection with resistant organisms. Underdosage of antimicrobial agents in answer E leads to the emergence of resistant pathogens. Antimicrobial stewardship in answer B aims to improve clinical outcomes by minimizing inappropriate use of antimicrobial agents and the emergence of resistant pathogens. For more information on antimicrobial stewardship, see the IDSA website http://www.idsociety.org/. for antimicrobial stewardship literature. Pharmacists should play a key role in an antimicrobial stewardship program. Pause the video and carefully scrutinize the lab results in the table showing MICs and breakpoints. On the basis of the above culture and susceptibility data, which regimen is now most appropriate for AS? Is it A. Piperacillin, tazobactam, or B. Ceftazidime plus gentamicin, or C. Meropenem plus gentamicin, or D. Ciprofloxacin plus gentamicin, or is it E. Ciprofloxacin? Answer A is correct. On the basis of culture and susceptibility data, piperacillin, tazobactam in answer A is the most appropriate agent based on MIC data and being the most narrow-spectrum agent compared to meropenem. It is the most susceptible agent listed with an MIC of 4 and a breakpoint of 16. The MIC is 2 dilutions away from the breakpoint, whereas ceftazidime is only 1 dilution away from the breakpoint, therefore, resistance may emerge. Historically, pseudomonal infections were generally treated with 2 drugs for synergy purposes. Synergy occurs with a beta-lactam and an aminoglycoside. However, a body of literature supports that you can discontinue the aminoglycoside or other dual therapy agents once susceptibilities are known for the pseudomonal isolate being treated. Overall, the guidelines suggest that monotherapy may be appropriate if the culture does not demonstrate a resistant pathogen. A narrow-spectrum antimicrobial agent would be better than using meropenem in answer C, a broad-spectrum antibiotic, because sensitivities are known. Ciprofloxacin plus gentamicin in answer D is probably the only additive in coverage, however, some believe that the combination is synergistic. ciprofloxacin in answer E, with or without gentamicin, or ceftazidime plus gentamicin in answer B, will not provide anaerobic coverage, which is optimal when treating a perforated ulcer. My fourth question to you is, 2 days later, you are on rounds and notice that AS's serum creatinine has increased from 1.2 mg per deciliter to 2.4 mg per deciliter. Which of the following statements regarding his antimicrobial therapy is true? He is currently receiving meropenem 2 grams via intravenous piggyback every 8 hours and gentamicin 160 mg via intravenous piggyback every 12 hours. A. Change regimen to piperacillin, tazobactam plus tobramycin. Or B. Consider discontinuation of gentamicin. Or C. Recommend that the meropenem dose interval be adjusted to 1 gram every 12 hours. Or D. Change regimen to ciprofloxacin. Or is it E, both B and C? Answer E is correct. AS's creatinine clearance has decreased from 56 ml per minute to 28 ml per minute using the Cockcroft-Gault equation and ideal body weight. As aminoglycosides can cause nephrotoxicity, it is reasonable to recommend that the gentamicin be discontinued in answer B. Meropenem is renally eliminated, and the manufacturer recommends a dosage adjustment at creatinine clearance of 26 to 50 ml per minute to 1 gram every 12 hours in answer C. Failure to adjust dosage may increase the risk of adverse effects, including seizures. Imipenem cilastatin has a higher risk of seizures than meropenem, however, a risk exists with meropenem. On the basis of susceptibilities, Pseudomonas is sensitive to piperacillin, but tobramycin is an aminoglycoside, which can still worsen AS's renal function. It would not be a reasonable option to change therapy to piperacillin plus tobramycin in answer A. It is also not reasonable to change the regimen to ciprofloxacin alone, as the patient requires anaerobic coverage for his perforated ulcer in answer D. And my fifth question to you reads, a physician orders ceftazidime 2 grams via intravenous piggyback every 8 hours for a patient with an Enterobacter species nosocomial pneumonia. Susceptibility testing shows that the pathogen is susceptible to ceftazidime. The patient initially responds to therapy but subsequently worsens. What has potentially happened? Is it A. Enterobacter possesses an inducible beta-lactamase gene, that is type 1 beta-lactamase enzyme, that in the presence of a beta-lactam induces this enzyme? Or B. Alteration in DNA gyrase is causing resistance? Or C. Underdosage of the ceftazidime has induced resistance? Or D. Non-adherence? Or is it E. Ceftazidime does not penetrate into the lung? Answer A is correct. Enterobacter species may contain inducible beta-lactamase genes that in the presence of ceftazidime, a third-generation cephalosporin, may be induced in answer A. Both Klebsiella and Enterobacter species may contain extended-spectrum beta-lactamases. In these cases, the carbapenems appear to be first-line therapy. Therefore, what shows to be susceptible in the lab is not actually susceptible in vivo. Beta-lactam agents are cell wall active agents, therefore, alterations in the DNA gyrase of organisms will not affect their activity against an organism in answer B. Quinolones act on DNA gyrase. Although underdosing may promote the emergence of resistant organisms, ceftazidime at a dose of 2 grams every 8 hours is not underdosed in answer C. Patient non-adherence rarely plays a role in the inpatient setting in answer D. Ceftazidime has adequate lung penetration in answer E. And my sixth question to you reads, which of the following oral antibiotics could be used to complete treatment of pneumonia for AS as an outpatient? Could it be A. Meropenem, or B. Cefuroxime, or C. Amoxicillin, clavulanate, or D. Ciprofloxacin? Or could it be E. Moxifloxacin? Answer D is correct. On the basis of culture and susceptibility data, ciprofloxacin in answer D is the only listed agent that is active against the Pseudomonas aeruginosa. Meropenem does not come as an oral agent in answer A. Cefuroxime in answer B, amoxicillin, clavulanate in answer C, and moxifloxacin in answer E do not have activity against Pseudomonas aeruginosa. Our next patient, named Tina Douglas, is aged 56 and belongs to the female gender. Her height is 5 feet 7 inches and she weighs 65 kg. She belongs to the white race. She is allergic to sulfur drugs, to which she developed a rash. Regarding her chief complaint, T.D. is a 56-year-old female who presents to her physician with a one-day history of fever, weakness, and body aches. Regarding her history of present illness, T.D. reports fevers to 102 degrees Fahrenheit that caused her to call in sick at work today. T.D. also reports that her appetite has been poor and she hurts all over. She has tried to increase her fluid intake but states that she just doesn't feel like eating or drinking anything. She babysat her 2-year-old grandson this weekend, and he was diagnosed with the flu yesterday. Fearing the flu, T.D. decided to report to her physician for an evaluation. On presentation to her physician, her temperature was 103 degrees Fahrenheit. A review of systems is negative except as noted previously. Regarding her past medical history, T.D.'s only past medical history is hypertension for the last 6 years and a history of a tonsillectomy at age 15. Regarding her social history, she is married. She lives with husband and has 2 grown children. She doesn't use tobacco. She rarely socially uses alcohol. She denied drug use. Regarding her family history, her father died of myocardial infarction 10 years prior. Her mother is alive and well. On physical examination, she is generally a well-developed, well-nourished female in moderate distress. Her vital signs on clinic presentation include a blood pressure of 140 systolic, 82 diastolic. Her heart rate is 100 beats per minute. She has a respiratory rate of 18 breaths per minute. Her body temperature is 39.4 degrees Celsius. She weighs 65 kg. Regarding head, eyes, ears, nose, throat, pupils equally round and reactive to light and accommodation. Her oral cavity is without ulcers or lesions. On chest examination, some coarse breath sounds are noted. Her abdomen is soft and non-tender. On neurologic examination, she is alert and oriented on 3 occasions. A genitourinary exam is deferred. Her laboratory and diagnostic test results are as follows. Sodium levels of 140 milliequivalents per liter. Potassium levels of 4.1 milliequivalents per liter. Chloride levels of 102 milliequivalents per liter. Bicarbonate content of 26 milliequivalents per liter. She has a blood urea nitrogen of 16 mg per deciliter. Her serum creatinine is 0.8 mg per deciliter. Her blood glucose levels is 100 mg per deciliter. Hemoglobin is 13.1 grams per deciliter. Her hematocrit is 39.3%. Her platelet count is 270,000 cells per millimeter cubed. Her white blood cell count is 5,900 cells per millimeter cubed with 50% segs, 1% bands, 40% lymphocytes, and 9% monocytes. Her nasopharyngeal swab is positive for influenza A virus. A diagnosis of influenza is made. Regarding her medication record, her home medications include Tylenol 500 mg orally pro Renata. Enalapril 20 mg orally daily. Aspirin 325 mg orally daily for coronary artery disease prevention. So my first question to you reads, what agents are recommended by the Centers for Disease Control and Prevention (CDC) for treatment and/or prophylaxis against influenza? Oral oseltamivir and inhaled zanamivir are recommended for both prevention and treatment of influenza A and B. In 2014, the U.S. Food and Drug Administration approved Rapivab, marketed as Peramivir, to treat influenza infection in adults, but it is available only in IV form. Amantadine and rimantadine are adamantanes, and they are not currently recommended by the CDC for the prevention or treatment of influenza A, because of widespread adamantane resistance among currently circulating influenza A viruses. The adamantanes are not active against influenza B. And my second question to you reads, what is the mechanism of action of the neuraminidase inhibitors? Neuraminidase catalyzes the hydrolysis of terminal sialic acid residues from newly formed virions and host cell receptors, allowing virions to be released from the infected cell. Hence, a neuraminidase inhibitor blocks the release of new influenza A and B virions. My third question to you reads, develop an appropriate treatment plan for TD at this time. Of the available treatment options, oseltamivir 75 mg orally twice daily for 5 days would be the most appropriate initial choice for the treatment of influenza A in this patient. Longer durations may be considered for patients who remain severely ill after 5 days of therapy. Zanamivir 10 mg inhaled twice daily for 5 days is another appropriate option. Peramivir is also an option, but it is available only via the IV route. Prophylaxis dosing may be administered for 7 CDC 2012 or American Academy of Pediatrics 2013 to 10 days manufacturer recommendation. And my fourth question to you reads, what, if any, clinical benefit is likely to be seen by starting antiviral treatment in TD at this time? Treatment of influenza with an anti-influenza agent will shorten the duration of the illness by an average of 1 day when started within 48 hours of symptoms. Clinical benefit is greatest the earlier the antiviral medication is initiated. Early antiviral treatment will also reduce the risk of complications from influenza such as pneumonia and death. However, treatment will not prevent influenza from occurring in subsequent seasons and will not eliminate the need for future vaccinations in subsequent flu seasons. Antiviral treatment might benefit patients with severe, complicated, or progressive illness, and in hospitalized patients when started after 48 hours of the onset of symptoms. And my fifth question to you reads, which of the following patients would be an appropriate candidate for vaccination with a standard dose, inactivated influenza vaccine? Would it be A. a 3-month-old healthy infant? Or B. a 45-year-old man with a history of an anaphylactic reaction to the inactivated influenza vaccine? Or C. a 28-year-old pregnant woman? Or D. a 15-year-old with a moderate to severe illness associated with fever? Or would it be E. a 68-year-old woman who developed Guillain-Barré syndrome within 6 weeks of receiving the influenza vaccine in the past? Answer C is correct. The standard dose, inactivated influenza vaccine is approved for use in pregnant women, while the quadrivalent, live-attenuated influenza vaccine is contraindicated in pregnant women. The inactivated influenza vaccine is not approved for use in children less than 6 months of age, in answer A. A previous severe allergic reaction to influenza vaccine is a contraindication to future receipt of the vaccine, in answer B. Patients who have developed Guillain-Barré syndrome within 6 weeks of receiving influenza vaccine in the past generally should not receive the vaccination again, in answer E. The influenza vaccine is not recommended for patients with a moderate to severe febrile illness, in answer D, because the vaccine may not be as effective during the acute illness. And my sixth question to you reads, which patient groups are candidates for the quadrivalent, live attenuated influenza vaccine? The live attenuated influenza vaccine is indicated for healthy, non-pregnant persons aged 2 to 49 years. Contraindications to the quadrivalent, live attenuated influenza vaccine include pregnancy, immunosuppression, history of an egg allergy, and patients who have taken influenza antiviral medications within the previous 48 hours. Precautions for the live attenuated influenza vaccine are moderate or acute illness, a patient history of Guillain-Barré syndrome within 6 weeks of vaccination, and patients with chronic medical conditions such as chronic lung diseases, diabetes, renal or hepatic diseases, hematologic diseases, neurologic diseases, and metabolic diseases. The demographics of a patient named Melanie Bossier who is aged 55 and belongs to the female gender is as follows. Her height is 5 feet, 6 inches. She weighs 155 pounds and belongs to the Caucasian race. She has no known drug or food allergies. Regarding her chief complaint, MB is a 55-year-old white female seen in her doctor's office yesterday afternoon complaining of weight loss and shortness of breath with exertion. Regarding her history of present illness, MB notes that for the past few months she has had a low-grade temperature, has been awakened often during the night because of excessive sweating and has had a weight loss of about 20 pounds over the past 2 months. MB's husband complains that during this period of time, she has also been coughing constantly. MB admits to occasionally coughing up blood during these coughing attacks. Upon further questioning, she mentions recently spending a 4-day vacation with her sister and family of 4 at their cabin near Lake Tahoe, California. A review of systems is negative except as noted previously. Regarding her past medical history, MB is postmenopausal and has a diagnosis of mild hypertension, hypothyroidism, and gout, which are being adequately managed with her current medication regimen. Regarding her social history, MB is married and has a grown daughter and 5 grandchildren who live with her. She is not a smoker but regularly drinks at least 1 glass of wine or beer with dinner. Her family history is non-contributory. On physical examination, her vital signs include a body temperature of 99.8 degrees Fahrenheit, a heart rate of 84 beats per minute, a respiratory rate of 24 breaths per minute, a blood pressure of 135 systolic and 72 diastolic. On examination of her skin and extremities, there is no rash, cyanosis, clubbing, or edema. On examination of the neck it is supple, with no lymphadenopathy. An examination of the lungs reveals babesillar rales and apical crackles on deep inspiration. On neurologic examination, she is alert and oriented on 3 occasions. Laboratory and diagnostic test results are as follows. She has a white blood cell count of 9,800 cells per millimeter cubed. Her hemoglobin is 12 grams per deciliter. She has a hematocrit of 38%. Her serum creatinine is 1.3 milligrams per deciliter. Her serum bicarbonate is 26 milliequivalents per liter. Her blood glucose levels are 142 milligrams per deciliter, that is non-fasting. Her free T4 is 1.5 nanograms per deciliter. Her TSH is 1.6 million international units per liter. Her aspartate aminotransferase is 45 international units per liter. Her alanine transaminase is 30 international units per liter. Her chest X-ray shows a right lower lobe infiltrate with bilateral hilar and right paratracheal adenopathy. There is evidence of old cavitary lesions in both apices. A diagnosis of tuberculosis is made. Regarding her medication record, she takes Premarin conjugated estrogen 1.25 mg daily, amlodipine 10 mg daily, levothyroxine 0.15 mg daily and allopurinol 300 mg daily. And my first question to you reads, on the basis of the information provided, tuberculin screening skin tests, that is the purified protein derivative, should be given to which family members? The purified protein derivative skin test, also called the Mantoux test, is used to detect Mycobacterium tuberculosis (MTB) infections in individuals with subclinical disease, that is latent infection. Infection can lead to positive purified protein derivative reactions within 6 to 8 weeks of exposure. Those individuals with a history of significant exposure to a known case of active TB should be screened for infection using the purified protein derivative skin test. In this case, because MB's husband, grown daughter, grandchildren, sister, and her sister's family all have significant exposure, they all should be screened with the purified protein derivative skin test. My second question to you reads, the patient's husband has a positive reaction within 48 hours of administration of a purified protein derivative skin test. What is considered a positive reaction of a purified protein derivative skin test? A reaction of greater than 5 mm to 5 Tu Mantoux test after 48 hours is considered positive for those patients with recent close contact with infectious TB cases and also for patients who are HIV positive, persons with fibrotic changes consistent with old healed TB, patients with organ transplants, and other immunosuppressed patients. A reaction of greater than 10 mm is positive for patients who are recent arrivals from high-prevalence countries, IV drug users, residents or employees of high-risk congregate settings, mycobacteriology lab personnel, persons with clinical conditions that place them at risk, children less than 4 years old, and adolescents exposed to adults in the high-risk category. A reaction of greater than 15 mm is positive for patients with no TB risk factors. The area of induration measures a patient with a positive TB reaction. Erythema is not considered. Tests must be read in 48 to 72 hours for an accurate reading. My third question to you reads, which one of the following statements is false regarding the quantiferin TB Gold in Tube test abbreviated as QFTGIT? Is it A? It may be used to diagnose both latent and active TB infections. Or B. Quantiferin TB Gold in Tube should be used in place of a purified protein derivative skin test, but not in addition to a purified protein derivative skin test. Or C. A prior BCG Bacillus calmette-guerin vaccination does not cause a false positive result. Or D. The patient must return to clinic within 48 to 72 hours to assess the reaction. Or is it E. Quantiferin TB Gold in Tube is not preferred over a purified protein derivative in children less than 5 years of age? Answer D is correct. In 2007, the quantiferin TB Gold in Tube test was approved by the FDA for use as a diagnostic test for both latent and active M. tuberculosis infections, as in answer A. Current CDC guidelines state that the quantiferin TB Gold in Tube test may be used in place of a PPD in all situations in which CDC recommends TST, tuberculin skin testing, as an aid in diagnosing M. tuberculosis infection, as in answer B. Unlike the purified protein derivative skin test, the QFT-GIT results may be available within 24 hours and don't require a return visit to the clinic, as in answer D. False positives do not occur if the patient has had a previous BCG vaccine, as in answer C. The CDC has specific recommendations available as to certain situations in which either the purified protein derivative or the quantiferin TB Gold in tube tests would be preferred over the other, as in answer E. One example included is that in children under the age of 5, the purified protein derivative test is preferred over quantiferin TB Gold in tube test due to its lack of data in this population. And my fourth question to you reads, what is an initial appropriate treatment recommendation for MB's pulmonary TB disease? In addition to the specific anti-TB regimen selected, what other therapy should be considered for MB at this time? For initial empiric treatment of TB, a 4-drug regimen consisting of isoniazid, rifampin, pyrazinamide, and ethambutol or streptomycin is recommended. The short course or 6-month regimen is preferred for therapy of TB. This consists of 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol or streptomycin, followed by 4 months of isoniazid and rifampin. TB should be treated with at least 2 agents that the organism is susceptible to in order to prevent the emergence of resistance. The 6-month course is the shortest duration of effective therapy. Treatment should be continued for at least 6 months from the time of a negative smear and culture. If pyrazinamide is not included in the initial regimen, treatment should continue for 9 months. Directly observed therapy (DOT) is recommended for treatment. Many clinicians consider adding daily doses of pyridoxine 25 to 50 mg in patients who are treated with isoniazid to offset potential neurological side effects of isoniazid therapy. And my fifth question to you reads, MB's liver function tests increased to 2 times the original concentrations after 1 month of therapy with isoniazid, rifampin, pyrazinamide, and ethambutol. MB does not have any complaints regarding her drug therapy, other than having to take so many drugs in a single day. Which of the following should not be a recommended change to her drug therapy? Is it A. Decrease the dose of isoniazid to half the starting dose, discontinue the rifampin? Or B. Interview the patient monthly for symptoms of hepatotoxicity? Or C. Inform the patient of symptoms of hepatotoxicity and tell her to report these to her doctor if they occur? Or D. Maintain the original doses of isoniazid, rifampin, and pyrazinamide? Or is it E. Monitor liver function tests for the entire course of therapy? Answer A is correct. In the presence of symptoms, elevation of liver function tests to 3 times the normal range may warrant discontinuation of drug at least temporarily. If no symptoms are present, continuation of medications until the liver function tests are over 5 times the normal range may be reasonable, as in answer A. Choices B through E can be recommended. And my sixth question to you reads, one of MB's grandchildren has a positive reaction to the purified protein derivative skin test. What therapy, if any, should be initiated in this 6-year-old male who is otherwise healthy and without clinical evidence of TB? Prophylaxis, that is treatment of latent TB infection, with isoniazid is recommended for those individuals who have a new conversion of a purified protein derivative and no other clinical manifestations of TB. The appropriate dose of isoniazid is 10 to 15 mg per kilogram per day, with a maximum dose of 300 mg, for 9 months. Moxifloxacin should not be used in pediatric patients. Rifampin can be used as an alternative to isoniazid. Ethambutol has not been used as a single agent for TB prophylaxis. The demographics of a patient named Victor Thompson, aged 59 and belonging to the male gender, are as follows. His height is 5 feet 5 inches. He weighs 160 pounds. He belongs to the white race. He has no known drug or food allergies. Regarding his chief complaint, VT is a 59-year-old male who presented to the ED by EMS after an apparent seizure he had at his group home around 2 p.m. today. Regarding his history of present illness, currently, the patient is very drowsy and unable to answer questions consistently. He is oriented only to self and place. No caregivers are in attendance, and he is a poor historian. He reports pain in his chest on the right side. The patient was recently seen in the ED 3 days ago for a sore throat, fever, and rhinorrhea. He was presumed to have acute pharyngitis and was administered penicillin G benzathine 1.2 million units IM as a stat dose. The clinical team is unable to obtain a review of systems. Regarding his past medical history, he suffers from hypertension, COPD, and bipolar disorder. Regarding his social history, he quit tobacco use 2 years ago. He has smoked 2 packs per day for 35 years. He denies alcohol or illicit drug use. Regarding his marital status, he is single. He has lived in a group home the past 8 years. His family history is unknown. Regarding his vaccine history, he received TD 6 years ago, and an influenza vaccine 4 years ago. His childhood series is up to date. On physical examination, he is generally a middle-aged male, very drowsy, oriented to self and place. His vital signs include a blood pressure of 117 systolic 62 diastolic. His heart rate is 111 beats per minute. He has a respiratory rate of 18 breaths per minute, and a body temperature of 98.3 degrees Fahrenheit. He weighs 160 pounds. Regarding head, eyes, ears, nose, throat, pupils equally round and reactive to light and accommodation but sluggish, face flushed, not compliant with neuro exam, so cannot fully assess extraocular muscles. He will not open mouth for evaluation. On chest examination, he has tachycardia with no murmurs, rubs or gallops appreciated, bilateral course inspiratory crackles and rhonchi, crackles locally increased to right lower lobe. On abdominal examination it is soft, non-tender. He is obese. Bowel sounds are normal. His extremities have 2+ pulses, and no clubbing, cyanosis, or edema. His laboratory and diagnostic test results are as follows. Sodium levels of 138 milliequivalents per liter. Potassium levels of 3.9 milliequivalents per liter. Chloride levels of 93 milliequivalents per liter. Bicarbonate content of 30 milliequivalents per liter. A blood urea nitrogen of 21 mg per deciliter and a serum creatinine of 1.67 mg per deciliter. His blood glucose levels are 132 mg per deciliter. His calcium levels are 9.8 mg per deciliter and the hemoglobin is 13.4 grams per deciliter. He has a hematocrit of 41.6% and a platelet count of 298,000 cells per millimeter cubed. His white blood cell count is 16,200 cells per millimeter cubed with 68% segs, 20% bands. On his chest X-ray, a right lower lobe infiltrate is seen. It was not seen on the chest X-ray 72 hours prior. According to his ECG, he has sinus tachycardia with premature ventricular contractions, and a QTc of 527. A pH of 7.269, and a bicarbonate of 35.8, ApCO2 of 78, and ApO2 of 45. A diagnosis of healthcare-associated pneumonia (HCAP) is made. According to his medication record, his home medications include albuterol 2 puffs every 6 hours, Pro Renata for wheezing or shortness of breath, clonidine 0.2 mg orally twice daily, fluoxetine 20 mg orally daily, Olanzapine 15 mg orally disintegrating tablet every night at bedtimes. Hydrocodone with homatropine 1 teaspoon orally 4 times daily. Pro Renata for cough. His inpatient medications include piperacillin, tazobactam 3.375 grams via intravenous piggyback stat. Vancomycin 20 mg per kilogram via intravenous piggyback stat. So my first question to you is, the medical resident needs to initiate therapy for VT and asks if he should administer ceftriaxone alone or a combination of levofloxacin and vancomycin. What is the best response to the resident? VT is diagnosed with healthcare-associated pneumonia, abbreviated as HCAP. Ceftriaxone is a commonly used single-agent therapy for patients with hospital-acquired pneumonia and no known risk factors, but it is not appropriate for healthcare-associated pneumonia therapy. Levofloxacin and vancomycin are appropriate if an anti-pseudomonal cephalosporin, anti-pseudomonal carbapenem, or beta-lactam, beta-lactamase inhibitor is added to therapy. A 3-drug combination antibiotic regimen is warranted as empiric therapy for healthcare-associated pneumonia in patients with risk factors for multi-drug-resistant pathogens. VT has risk factors of antimicrobial use in the past 3 months and potential group home residential situation. And my second question to you is, which antibiotics potentially used for healthcare-associated pneumonia have post-antibiotic effects? Aminoglycosides and fluoroquinolones exhibit post-antibiotic effect against gram-negative bacilli. Beta-lactams usually have little to no post-antibiotic effects. Carbapenems are an exception to this as they have post-antibiotic effects against gram-negative bacilli. My third question to you reads, what if you had a patient with pneumonia and Acinetobacter species was the causative pathogen? What antibiotics are the most active against this species? Acinetobacter species has native resistance to several antibiotic classes. If Acinetobacter species was a causative pathogen in pneumonia, carbapenems, ampicillin, sulbactam, polymyxin B, and colistin are the most active antimicrobials. A carbapenem is an appropriate empiric therapy. The activity of ampicillin, sulbactam against Acinetobacter comes from the sulbactam component. Nephrotoxic effects of polymyxin B and colistin may limit its use depending on patient factors, however, aerosolized therapy may be considered. My fourth question to you reads, what should the clinician do if the patient is not responding to initial therapy? If a patient is not responding to initial therapy, the organism, diagnosis, and complications should be considered. First, question if the patient has a different organism than originally expected or if the patient has an inadequate antimicrobial therapy. Ensure the drug can reach the infection site in the body, considering issues such as absorption or chelation. Could other diagnoses be relevant, or could complications have occurred? Host, pathogen, and therapeutic factors should all be questioned and considered. And my fifth question to you reads, in evaluating his vaccine record, does VT need any immunizations at this time or in the future? VT should receive the tetanus, diphtheria, and pertussis vaccine abbreviated as Tdap vaccine at this time. If available, he should also receive the inactivated influenza vaccine annually. VT should not receive the live attenuated influenza vaccine due to his pulmonary disease. However, because of his pulmonary disease, he should receive the pneumococcal polysaccharide vaccine abbreviated as PPSV23 vaccine at this time. 1 year from now he should receive the pneumococcal conjugate vaccine abbreviated as PCV13, and 5 years from now he should receive another pneumococcal polysaccharide vaccine. Once he turns 60 years of age, he should receive the zoster vaccine. And my sixth question to you reads: if VT had a history of experiencing shortness of breath with amoxicillin use, what medication would have been an appropriate treatment for the presumed acute pharyngitis? If VT had a history of a severe allergic reaction with amoxicillin, then it would have been best to use an alternative such as clindamycin, azithromycin, or clarithromycin to treat the acute pharyngitis. Penicillins and cephalosporins should be avoided. First-generation cephalosporins could be used if the patient had experienced a non-IgE-mediated reaction. Thank you.